So you all know that in last year, 2020, there are the new EC guidelines for the treatment, the diagnosis and treatment of atrial fibrillation. And this guideline shows that so upgrade of indication of catheter ablation in atrial fibrillation. So catheter ablation is a class 1 indication for paroxysmal atrial fibrillation and also for the persistent atrial fibrillation. And the STAR-F study has shown what to do in atrial fibrillation. It has compared so pulmonary vein is isolation with additional atrial ablation in lines or electrograms. And this study has shown that the pulmonary vein isolation is same effective than ablation in the left atrium, so that the guidelines mention that the complete electrical isolation of the pulmonary vein is recommended during all AF catheter ablation procedures. So this is the cornerstone, the pulmonary vein isolation is the cornerstone in catheter ablation of pulmonary ablation, still in 2021. But the new guidelines mention also that the characterization of the substrate of atrial fibrillation will be more and more important. And so atrial enlargement and fibrosis, so the characteristic of the substrate. And we know the studies from the Marouche group is more than 10 years old, but it's still actual, that the left atrial strain and strain rate in patients with paroxysmal or persistent atrial fibrillation is related to the left atrial structural remodeling detected by MRI. And you see here the correlation of the grade of atrial fibrosis to left atrial function parameters like left atrial strain. And the authors concluded that LR wall fibrosis by MRI is inversely related to L strain and strain rate, and these are related to AF burden. So echocardiographic assessment of LS structural and functional remodeling is quick and feasible and may be helpful in predicting outcomes of AF. And the Knebel's group from Berlin have investigated the left atrial mechanics and have concluded that the left atrial mechanics predict the success of pulmonary vein isolation patients with atrial fibrillation. And you see here the 2D strain derived reservoir function of patients, and in the patient where the reservoir function is preserved, they are good responders in catheter ablation of atrial fibrillation, whereas patients who have decreased reservoir function were non-responders after catheter ablation. So in summary, the left atrial size of volume index is not a sufficient parameter of LF function, and the functional remodeling is more important than structural remodeling. The correlation of LS strain, speckle tracking, and fibrosis in cardiac MRI and LS strain is predict outcome after PVI. And so the impact of atrial contribution in patients with HFpEF is outstanding, and the prognosis may depend on systolic and diastolic LF function. So that is the so-called DCAF2 study ongoing. This is a prospective study, and this study wants to investigate in consequence to these findings, the fibrosis guided versus conventional AF ablation, and the estimated follow-up completion is this year. And we are very excited to see the results of this study. Now, concerning atrial fibrillation heart failure, there's an interesting study published 4 years ago, the so-called camera MRI study. In this study, have compared patients who were who were sufficient rate controlled with medical drug therapy. Have compared them to patients who have underwent in catheter ablation. And so this study wants to show the additional benefit of catheter ablation despite sufficient rate control. And here are the results. You see here that the left ventricular ejection fraction is improved after catheter ablation comparing to medical rate control. And so that this study wants to highlight that only the rate control is not enough for patients with heart failure. And this landmark study, the Castle study, you all know the study. This study was the first trial that has shown the better outcome in patients after catheter ablation comparing to medical therapy. So that were patients who have severe heart failure with implanted ICD or CRT, and these patients um, have significant better outcome after catheter ablation comparing to medical therapy. So that the actual guidelines of 2020 mentioned that catheter ablation is recommended to reverse LV dysfunction in tachycardia-induced cardiomyopathy, class 1 indication, and also in patients, in selected patients with have REF with heart failure with reduced ejection fraction to improve survival, and reduce heart failure hospitalization with a 2A recommendation. Now, this is a clinical case report of one patient in our clinic with a patient with long-standing atrial fibrillation with elevated heart rate, and initial ejection fraction is very reduced, is highly reduced, 32% AF, and we could not directly cardiovert this patient because he has had an LLA thrombus, and so we have to control the heart rate and do some anticoagulation. And you see here, under controlled heart rate, the ejection fraction is still reduced. And here at this time, we, after resolution of the LLA thrombus, we have cardiovert and ablate these patients. And in sinus rhythm, you see here the restored LV ejection fraction and the norm of a full like reverse remodeled left atrium. Here you see the large left atrium, and here normalized left atrium size. And these slides, I want to only mention here the increased booster function in sinus rhythm after restoring of the sinus rhythm. Well, when to perform catheter ablation of atrial fibrillation. So I want to give you some rationale for early rhythm control strategy. As you all know, that atrial fibrillation is a progressive disease, and there are some studies that have shown that there's a marked transition from proximal states of atrial fibrillation in persistent or permanent state. And so here, for example, a PET film in 2017 shows a 4 to 15% progression from paroxysmal atrial fibrillation to persistent forms per year, depending on age, sex, cardiovascular risk factors. And so the early rhythm control strategy to stop and delay progression may be favorable. So Collins-Cook, in line with this, Collins-Cook have published the so-called ATTEST study. And the thesis of this study is that catheter ablation can delay progression from proximal to persistent atrial fibrillation. And the studies have included a typical population of paroxysmal atrial fibrillation patients with age more than 60 years with paroxysmal atrial fibrillation, and have randomized in an RF ablation group with pulmonary vein isolation and an antiarrhythmic therapy group. And you can see, as you can see here clearly in the results, that there's a significantly lower rate of persistent AF or AT with ablation than with antiarrhythmic drug therapy. So the patients undergoing RF ablation were about 10 times less likely than antiarrhythmic drug patients to develop a persistent AF. So that the authors concluded that in patients with drug refractory paroxysmal atrial fibrillation, An early RF ablation was superior to antiarrhythmic drug therapy in delaying progression to persistent atrial fibrillation. So in line of this, last year, that was also a landmark study published on the group of Paulus Kirchhoff, the so-called East AFNet 4 trial. And this big trial have investigated early rhythm control therapy in patients with atrial fibrillation. And these are the study data. Is more than 2,800 patients were randomized in an early rhythm control strategy versus an rate control strategy. And the rhythm control were achieved with drugs and or atrial fibrillation ablation. That was the result of the study. See here that the early rhythm control study was significantly superior for the first primary outcome, which included death from cardiovascular causes, stroke, acute coronary syndrome, hospitalization with worsening of heart failure. And so this study highlights that the early rhythm control therapy may be beneficial for patients with atrial fibrillation. And at the end of my talk, I want to show you one new technology. Sorry. Wait. Yeah, wait. Okay. Yeah. Okay. Zack. Okay. Can you see me? Yeah, okay. Want to introduce a new technology in catheter ablation, the so-called pulse field ablation, PFA. And to introduce is that the multiple catheter ablation technologies have been introduced over the last years, predominantly aiming at better and durable lesion formation to improve clinical success. And this has also led to a decrease of overall complications, but still severe complications such as tamponade, esophageal fistula, and PV stenosis do still occur. And the pulse field ablation has the potential to combine a high ablation success rate with no or minimal complications. The pulse field ablation, so-called PFA, is a form of irreversible electroporation that uses a train of bipolar and biphasic pulses of high voltage, more than 500 volts, and short duration to create tissue injury without significant heating. It's like small, short electroshocks in the pulmonary vein. And the mechanism of lesion formation in irreversible electroporation is a function of electric field exposures that break down cell membrane permeability, leading to cell death. And a unique feature of the pulse field ablation is tissue specificity. That means that the myocardium is very susceptible to irreversible injury, whereas the esophagus, phrenic nerves, pulmonary veins, and coronary arteries are relatively resistant to the injury. So the tissue specificity. Want to show you shortly some technical terms here. Here's the circular ablation catheter, and over a short time of 36 milliseconds, there are here biphasic and bipolar shocks pulses here with 500 volts here. And after a time of 36 milliseconds, you can see here cross ablation, the pulmonary vein electrograms will disappear. And so preparing to the normal radio frequency ablation, the effect is more impressive here. And you see here some histological images of the cell membrane. After 36 milliseconds, the cell membrane of the cardiomyocyte is damaged, and there's this cell death. You see here in the macroscopic preparation of the right atrial appendage, there's a continuous lesion after pulse field ablation. And important is that the fat tissue and here the blood vessels, they are still there. They are not damaged after this pulse field ablation. You see this, only the cardiomyocytes were ablated, and so sparing the epicardial fat and sparing also the intralesional arteries. So the Vivek Reddy from New York have done two nice short studies with these so-called Farapulse devices. This is the catheter, which is called Farapulse. It's two forms with a basket form or a flower form. And very important is the safety profile of this pulse field ablation catheter. So you can see here that there's only, in two short, small studies, only one cardiac tamponade as adverse event. And they have seen no other adverse events in this ablation procedure. No esophageal lesions, no phrenic paresis, no stroke. And then the 3D electroanatomical mapping showed nicely isolated pulmonary veins after pulse field ablation, and also the clinical success rate after pulse field ablation is very good. We have seen after 1 year, 87% of the patients still in sinus rhythm after pulse field ablation. So, ladies and gentlemen, so I'm very good in time. It's just 40 minutes. I want to summarize. So there are new ESC guidelines in 2020, and in these guidelines, the recommendation catheter ablation were upgraded. So defining structural and functional values for individualized substrate-based ablation strategies is very important. So early rhythm control strategy may be